We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, episode 23 of AMOGS Emergency Obstetric Committee with Porbandar, Junagadh, Bhavnagar, Jamnagar Societies of Gujrat. So it's my privilege to introduce the convener of today's webinar, Dr. Archana Dwivedi ma'am. Ma'am is the National Chairperson, IMS Website Committee from 23 to 25, President of Baroda OBGYN Society, President of MSV from 2019 to 20, and Secretary of WDWIMA for 2020 to 2022. I welcome you, ma'am, and I hand over the session to you. Ma'am, please unmute, ma'am. Archana.
It's a great honor and pleasure to me to host the prestigious AMOGS Educative Webinar under the wings of Dr. Sneha Madam's guidance. And I welcome Dr. Kiran sir, Dr. Vipin sir, Dr. Rajendra Pardesi sir, Dr. Madhavi ma'am, and of course Dr. Sneha Buyar ma'am, who has been a pioneer and continuous education process, which I'm also learning so many good things to do with her. So before I start the inauguration, let us have a prayer to God. Over to you, Saidi, for the same.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं.
Welcome dignitaries and all the societies from Gujrat, Porbandar, Jamnagar, Bhavnagar and Junagadh. We welcome you on behalf of AMOGS, and it's my proud privilege to introduce Dr. Sneha Buyar madam. We all consider you as our candidate for Vice President Foxy West Zone, a very hardworking person. She has been a guide and mentor during my work with Foxy Breast Committee Chairperson as 19 to 21. She also was a national aerosol trainer, WHO FPI certified, national expert to UNICEF peer review of Jogi, AMOGS Chairperson, Medical Disorders Committee 22 to 24, and also Emergency Obstetrics 24 to 26. Her mission Pink Health Committee and convener PCPNDT, CEPOC Working Group member on breastfeeding, and founder president ISOPAC Without Chapter. She was president of Yavatman Society 2007-8 and founder clinical secretary of YOGS 23. Life member of Foxy, IMA, ISAR, IAG, IMS, ISOPAC, and she's also having so many awards in her kitty. A few to mention, and signature award now of leadership 2020, Asia GCC Award 2021. And there are so many other awards, but what I like the most about her is her hard work and dedication towards the obstetric patients and every field, I would say. Passion to teach and share her experiences with us has guided us so many times, and it's my proud privilege to hand over the mic to you, Sneha ma'am, to introduce our
guests. Thank you so much. Thank you so much, my dear, for that, I would say, a very generous introduction. A very good evening to one and all. My respect and regards to our chief guest for today's program, Dr. Gangadhar Sahu, the immediate past president of, I would say, the past president of ISOPAP National, and of course, Dr. Narayan Jana, the current president of ISOPAP. The guest of honor for today's program, Dr. Harish Doshi. I'm sure everybody knows him so well. And our dear friend, Dr. Kalyan Baramde from AMOGS. She is the past committee chairperson of the Foxy Public Awareness Committee. And also we have a special guest, Dr. Neena Malhotra from AMS, who is the professor and head of Department of AMS Delhi. Of course, a very dear friend. Dr. Girija Wagh, who is the illustrious speaker for today's, will be speaking on the role of instrumental vaginal delivery with a special mention on the forceps delivery. And of course, the office bearers of AMOGS, I would like to thank them and welcome them Dr. Kiran Kurtakoti, the president, Dr. Bipin Pandit, Dr. Rajendra Singh Pardesi, immediate past president, and of course, our dear friend Dr. Parag Biniwale, who is the ICOG chairperson elect and national coordinator for AMOGS. I welcome respected chairpersons Dr. Deepak Bangade sir, Dr. Rajesh Doshi, and Dr. Monica Jindal Singh. And also I welcome the panelists, Dr. Piyush Kumar Vadalia, Dr. Renzinal Pincho, Dr. Manish Trivedi, Dr. Gautam Gaurav Rathi, Dr. Jay Bhatt, Ashish Kuchidia, and of course, my right and left, Dr. Archana Trivedi and Dr. Munjal Pandya, who has convened this program so well. And of course, the hardworking coordinators, Dr. Kirtan Vyas and Dr. Kazi. So Dr. Kazi is today busy celebrating his birthday in Srinagar. So we're going to miss him, but I'm sure everybody will take care of this. And with this warm welcome, I thank all of you for accepting this invitation and of course, gracing the program. Without much ado, we would like to go ahead with the blessings of God first, Saiti. Can we have the inauguration video, please? And then, of course, we will have the blessings of our respected seniors.
Yes, ma'am, it was already done.
Okay. So with the blessings of God Almighty, we go ahead with the program and may we have the blessings of our respected Dr. Gangadhar Sahu, who is the chief guest for today's program. And sir, I know you as the National President of ISOPUB, retired professor and HOD VSS Medical College, Budla Sambalpur, Dean of IMS and Some Hospital, Bhubaneswar. And I'm sure you are a teacher of teacher. Everybody knows you by your hard work and you're such a popular teacher. So we would like to have some words of guidance from you. Over to you, Dr. Gangadhar Sahu, sir.
Thank you, Sneha. Thank you for your invitation. My namaskar to you and all the esteemed guests of honor, chief guest Professor Jena, and special guest, the chairperson, speakers, delegates, and participants. So blessings from Lord Jagannath, greetings from my family, Odisha and ISOPUB. So at the outset, so I can say that the choice of the topic today that we are going to discuss is the role of forceps in modern obstetric practice. So few words regarding this. So how does this modern obstetric practice differ from conventional obstetric practice? So in one sentence, if I can say, obstetric practice has become defensive. That is number one. So we always calculate the loss and the gain, what will happen. And this sword of litigation is always hanging on our neck. So therefore, it is becoming day by day very problematic. So in this present obstetric practice, you will be surprised to know that you will not find a true obstetrician who dedicates his time, his patience, his work, everything towards obstetrics only, because so many diversions are there. Therefore, an obstetrician should be, while dealing with cases, are becoming very much special in the sense that they are dealing with two or more lives at one time. So even if it is a privilege that we admit one and discharge more than one, at the same time it is a risk also. The risk of one or more than one is always there with us. So therefore, as regards instrumental delivery, the trainers, number one, true trainers are now gradually, we can count them. So trainees, they have got no patience, no intention to learn these subjects. They think of endoscopy and something else. Of course, this forceps application should be treated as any other instrumental application in obstetrics or gynecology, maybe endoscopy or not. Therefore, before doing this practice, one should be adequately trained. So therefore, we say that if any instrument is given to an untrained person, it is more dangerous than a gun given to a mad monkey. So therefore, all precautions should be taken for the use of forceps in obstetric practice. There must be definite indication. The methods should be followed correctly. Documentation should be 100% perfect. And after delivery, your examination, starting from your abdominal examination to the perspiculum, pervaginal, and more specifically a perrectal examination, that is a must before discharging a patient. 1 hour, that is the golden hour following delivery, is a must. Traumatic PPH, atonic PPH, and combined both, that should be looked after for this forceps application. Also to the baby, examination for the risks of forceps application, because you are the first obstetrician to deal with, first neonatologist to deal with, you should take optimum care for the neonate also. Therefore, my dear friends, obstetric practice today is not that easy as it was 50 years back. So therefore, at every step, you must take necessary precautions, and if required, don't be miser to take a second opinion to stand behind you. Hopefully, the time is there to learn for and to bring this lost art of instrumental delivery again to the forefront and minimize the indication, the percentage or incidence of cesarean section. That will help in future. Once again, thank you, Sneha, for inviting me, and my namaskar to everybody. Jai Jagannath, Jai Sri Ram.
Thank you so much, sir. And without much ado, we would like to have the few words from our next chief guest, Professor Dr. Narayan Channa, who is the president of ISOPERP. And over to you, sir, for your words of wisdom.
Namaskar. Am I audible?
Yes, yes. Namaskar, sir.
Namaskar. And good evening. It's a great pleasure and an honor for me to be with you in this evening. Indeed, it's an opportunity for me first to invite you all to an organization which is totally dedicated for maternal and child health, the Indian Society of Perinatology and Reproductive Pathology. I know many of you are not still a member, but be with us and bring your friends to the organization. Once Lord Buddha said, Buddhang saranam gacchami, sangham saranam gacchami, dharmam saranam gacchami. If you cannot do alone, the sangha, the society can do together. And I admire this effort of Dr. Sneha to bring so many societies together in this webinar, particularly very important webinar, that is obstetric emergencies in labor. This is a very crucial moment for us because we are almost in the public health crisis due to epidemics of cesarean section. We were 17% in NFHS 4. Now we are around 22%. Every year we are increasing by 1%. And sometimes we will be creeping and going towards 30-35%, which is not affordable. Particularly a country like India, where there are almost 27 million deliveries in a year. And in that context, instrumental delivery, particularly process delivery, is a very important learning point for postgraduates. It is almost a lost art. Everybody is rushing for a cesarean section, and that has to be done towards process delivery, venous delivery. And this effort will be a great effort for all the learners who joined us and for all the teachers who will teach us. And with that, once again, I thank Dr. Sneha and the Emergency Obstetric Committee of AMOGS.
Thank you, sir. Thank you so much.
For inviting me to join in your webinar. Again, I invite you once again to join Indian Society of Perinatology and Reproductive Biology. Bring your friends, your students, your trainees to the society, which is totally dedicated for maternal and child health. Thank you. Wish you all a grand success of the webinar.
Thank you, sir. Thank you so much. And of course, now may we have few words of wisdom from Professor Dr. Harish Doshi. I'm sure everybody knows him, and sir is contesting for the post of Vice Chairperson of ICOG, a revered teacher and teacher of teachers, I would say. Sir, we would like to hear from you. Over to you, sir. Dr. Harish Doshi, please. So please unmute. Please unmute. I think so.
Okay.
Yeah.
Now you can hear me, no? Okay. Thank you, Madam Dr. Sneha. Also, all office bearers of AMOGS and office bearers of 4 societies of Gujrat, that is Porbandar, Junagadh, Bhavnagar, and Jamnagar, for inviting me in this webinar. The topics selected by Sneha Madam are very close to my heart. Instrumental delivery. I've been propagating it all over India and even abroad. And also then the panel discussion is there, that is of emergency situation in labor room. That is also because I'm a hardcore obstetrician. The need of the hour, as my two chief guests of ISOPA president and past president mentioned, is to not to stop this instrumental delivery practicing. Right? It is gradually becoming a vanishing art. So much so that in one exam, when I asked the candidate, I asked him the one blade of the instrument, forceps. He had not seen it, and his eye.
There's net lag there.
Network issues.
Right. Okay. So hello.
Yes, sir.
Can you hear me?
Yes, sir. Beach mein thoda
Hello.
lag raha tha. Yes,
Can you
we
hear
can.
me, Archana
Yes,
madam?
sir. Yes, sir. We can hear you.
Yes. So he was so surprised that it is like an alien. So that is just, I want to emphasize that these webinars are okay, good. These topics are discussed. But in labor room, in medical colleges, it should be taught to students. So when I come out, as Dr. Gangadhar said, that it is litigation pressure, because of litigation pressure, nowadays obstetrics is changing and people are not doing it. So need of the hour is to do it, continue it, and teach for our professors. Thank you, Madam Sneha. I will not speak much, and you can go ahead. All the best for your vice presidency.
Thank you. Thank you so much, sir. Thank you so much for your words of guidance. I'm sure everybody is blessed now, and we invite Dr. Kalyan Baramde, our dear friend from AMOGS, who is actually, we have worked together as chairperson in FOXY, and he was a former chairperson of FOXY Public Awareness Committee, at present the vice president of IAG, and is going to be soon the president of IAG. We are so proud of you, Kalyan, and we would like to hear from you. Over to you, Dr. Kalyan. Kalyan, please unmute. Please unmute.
Thank you, ma'am, for such a wonderful introduction. And this webinar is going to be really helpful because the topics are chosen as obstetrics topics and forceps, vacuum deliveries. We are losing the art of forceps deliveries. Even in cesarean section, we are not using much as so many elective cesarean sections are going on. But we are happy that maternal mortality rate of India as well as Maharashtra has come down to around, Maharashtra is 33. So this is a good sign, welcome sign. All peripheries, the doctors, gynecologists are working in small places also. That is the benefit that the maternal mortality rate has come down. But we need to be really judicious whenever you are using forceps and vacuum deliveries. The art is lost, and because of the such good webinars, it is going to be regenerated. I wish all the best for the success of this webinar. I wish Dr. Sneha Buyar, my colleague, my senior and mentor from Foxy, for her Foxy Vice President election. And I'll wish that she will win with a thumping majority. All the best to you, ma'am.
Thank you so much, Kalyan. Thank you so much
You are such a hardworking person. Foxy needs you more than anything else.
Thank you. Thank you so much. Thank you, Dr. Kalyan, once again. And Dr. Neena Malhotra, she is right now busy with some.
Ma'am has joined, ma'am.
Is
Yeah.
it?
Yes,
Oh,
ma'am.
She is
so we
there.
would
She is
be-
there.
Yes, we would be very happy to welcome you, rather, Dr. Neena. She's the professor and head of Department of OBGYN in AIMS, New Delhi, and she has, such a illustrious person with a highly decorated CV. I would say she has all studied with, the CV studied with all her research projects and funded projects and so many publications and awards and accolades. But more than that, what I would say, she's such a humble, genuine human being, always ready to help others. And of course, what would I say about her work? She's a very hardworking, genuine person, and she's also contesting for the chairperson for Imaging Science Committee for Foxy. So, best wishes to you. And Dr. Neena, over to you for your precious words.
Thank you, Dr. Sneha. I think at the outset, I'm really humbled and honored to be present here amongst such august seniors, learned teachers. I'm sorry, I just finished the interview from AIMS Guwahati and I'm here taking faculty interviews. If I miss some names, please apologize. Dr. Doshi, Dr. Kalyan Barmade, whom I just heard, so many of the Foxy seniors, including Dr. Bipin Pandit. I don't think I've exactly know who all have joined, but I'm sure they're all the seniors who are there in this webinar. I know that obstetrics is something which needs skill. It's a skill-driven field, a specialty where it's not the mother but the fetus. And I think as obstetricians, we are charged up and passionate on this side. And I think Dr. Sneha, who's very, very meticulously designed and crafted this program, has really thoughtfully thought of keeping the skills updated. I'm sure, as Dr. Kalyan and Dr. Doshi has pointed out, forceps is a dying art, and to really put it back in practice is no better way than doing it. I think what better way can we say technology? Today everybody sitting at all corners and look at technology helping us come down to the basics of learning obstetric forceps. So I think I wish this webinar all the best, and my good wishes to Dr. Sneha. And as you rightly said, I also need your blessings and support as I contest an election for the imaging science person. But all said and done, I think these are good ways not just to teach, but also to connect with each one of us. Thank you, Dr. Sneha. Thank you once again.
Thank you so much, Dr. Neena. And from AMOGS side today, I think Dr. Kiran Kurtakoti is now in traveling. He's in a flight, and we do have Dr. Parag Biniwale, the national coordinator of AMOGS, a very dear friend. I have already introduced you. So over to you, Parag, for your precious words.
Thank you, Sneha. I bring greetings from AMOGS, and as a national coordinator of AMOGS, it's indeed heartening to see the AMOGS Emergency Committee led by you growing beyond the boundaries of Maharashtra. So every day I'm attending activities which are with neighboring states and societies. Wonderful work that you are doing. We are really proud of you. My greetings to all our friends from SOGOG. special mention of Dr. Deepak Bagde, who happens to be a friend, if I may so, for last 20 odd years. Thank you, sir, for being here, and all dear friends from Gujarat. I'm looking forward to this particular session because the two key people, the first speaker, Dr. Girjawag, and of course, the second session moderated by Sneha, both happen to be my very close friends, and all of us have been friends for 35 years, and we've actually grown together as postgraduates in the Department of OBGYN at the BJ Government Medical College. Sneha, my best wishes to you for your forthcoming election, and my best wishes to Nina, Archana, Haresh is also there, and of course, Monica, for your forthcoming elections. Thank you so much.
Thank you, sir. Thank you.
Thank you so much, Parag, and I would just thank all of you for gracing the program and for all your blessings and best wishes. So without much ado, we move ahead with the academic session. Over to you, Dr. Archana.
Thank you so much. Thank you, dignitaries. We call the inaugural function or we open the webinar now. And for the first session, we have got an eminent speaker, Dr. Girjawag, madam, with us. To introduce her and the session, we have our chairpersons, Dr. Deepak Bagde, sir. I think he's a well-known person to all of us. First ever Sogo Goresh 2014. A very adorable person and a very dear friend. Maybe he's a senior, but very guiding force to most of us in Gujarat. He was also president Jamnagar Gynec Society, Jamnagar IMA, member board of studies, Saurashtra University, scientific committee chairperson for Gujarat State Gynecologist, and head of department MP Shah Medical College, Jamnagar. He has delivered about 62,000 babies in private practice since 1985. Commendable, sir. So we are having another chairperson, my dear friend Monica, who's there with us, and she is a very hardworking person. And we are looking forward to attend the VPCon in Bhopal, which you are organizing. And wishing you all the best. She is their zone coordinator for Medical Disorders Committee of Proxy right now. So welcome, Monica. Best wishes for elections too. And Dr. Rajesh Joshi, sir, who is a very senior person and also very humble person. He has passed MBBS from NHM Municipal Medical College, Ahmedabad. And he's practicing OB-GYN consultant, cynologist, and pioneer laparoscopic surgeon in Junagadh since 1983. He was also past president of Sohog in 1998. Over to you, dignitaries. You can introduce Dr. Girjawag, madam. Bagde sir, you can do the honors if you want to. Hello.
Yeah, okay. Can I take it over? Because then
Yes.
probably I'll have to leave. Okay, thanks, Archana.
Thank you, sir.
Sneha, Archana, Munjal, Kirtan, thanks for getting me to this wonderful webinar. Forceps, we are talking about forceps that I got. But the way the scenario is, down the line in 10 years, we'll be having the same webinar for a normal delivery. I won't be surprised. Because yes, forceps are going out of the way. But I'm lucky, and with my colleague, Dr. Rajesh Joshi also is here, who has been my room partner, who is my friend and everything, and we love forceps. Parag, if you remember, I don't know, Parag is still there? Okay, anyway. So Girija is also there. Girija, if you remember, we had an alarm course in 2004. And that time, we had revisited forceps and vacuum both. But that was a wonderful course. And to a dear friend, I would really say something, Dr. Nargolkar, who has presented me with his original Hess forceps. And that is really, really, really wonderful. Girija, knowing you, professor, a friend, a colleague, from whatever I say, a younger sister, what? Girija, you've been very close, want to meet you since years and years and years together. So, Sneha, it's wonderful to be with you again. And the way you are working hard, you deserve the post. Not to forget the post. Post is a side way. We require people like you in Foxy. So best wishes to you, Archana, Monica, Haresh, and Dr. Malhotra for your next endeavors.
Thank you.
Unfortunately, I'll have to leave because of some of my OPD patients. Girija, I won't be able to listen to you, but I'm sure you are going to do justice to the thing.
Yeah, you're going to miss.
The thing is, because my still forceps rate is 15% down to from 30% at a time. But it means 15% of the cesareans are being saved at even this time. And why are you afraid of forceps? I'm sure Girija is going to justify forceps like anything. Thank you. Thank you, Sneha,
Thank you, sir.
for getting
Thank
me
you.
to this.
Thank you so much for joining. Thank you, sir.
We can start screen sharing with Dr. Girija ma'am. Dr. Rajesh or Dr. Monica, would you like to put some inputs if you want to?
I am so honored.
Madam is sharing the screen. Yeah.
Yes, I'm so honored to chair the session of Dr. Girija Bagh, who happens to be. I seriously admire Madam for her talks and her knowledge. Every time she has communicated, she has delivered powerful messages from her clinical skills and almost encyclopedic knowledge of every subject related to obstetrics and gynecology. Apart from great wisdom, she imparts to all juniors. So, Dr. Sneha ma'am, I'm really thankful to AMOGS Emergency Obstetrics Committee, which has collaborated with SOGOG and involved me as a chairperson in this beautiful program. And special thanks to AMOGS office bearers, Dr. Kiran Kotkoti sir, Dr. Bipin Tanpandit sir, and past president, Dr. Padeshi sir. And especially to you, Sneha ma'am. And I must confess that when I started my practice way back after doing my MD and DNB in 97, I was practicing in a part of Bhopal, which was a sort of, a city area, very conservative area, where forceps, outlet forceps, especially, and it really saved me, saved my skin rather, where I could deliver babies, and avoid cesarean sections. And that gave me quite a lot of reputation also. So, I mean, I think I'm the generation between the seniors and the juniors who were the last to practice forceps actively. Though we'd never practiced in the gelants or chelants, we could not, sort of see them being applied. But we applied a lot of mid cavity, we did rotations, and we did a lots of outlet forceps. So, ma'am, I'm waiting to hear you. Thank you so much.
Thank you so much, Dr. Monica. And I now grab the screen because it's high time that we moved on with an academic session. With respects to the chairpersons, Dr. Doshi, Dr. Monica, and Dr. Deepak Bhakde, and all the stalwarts who are here on the screen just now. I'm very grateful to Sneha, my dear friend, for giving me this opportunity to share whatever is remaining of the forceps in this modern obstetrics. I completely do not agree to what my friend from Latur said, that we don't use forceps. Believe me, for all C-sections, we use forceps. And even today, there are many vaginal deliveries, which I very confidently do with forceps. Now, Sneha would agree to me that we were brought up in the Sassoon General Hospitals and Vijay Medical College, where vacuums never worked. So we had no choice but to learn forceps. And through hard times, self-learning and observing the seniors, we have seen all kinds of forceps, all sorts of wonderful relief which was given by them to patients, and all sorts of complications as well associated with a wrongly applied forceps. So thank you, Sneha, for giving me this opportunity. And I still believe in this art. And I will continue to teach and nurture this art as much as I live as a teacher. And this is something that we have to learn always. Now, I have decided to not only speak about forceps, because today no forceps talk can be without encompassing the entire instrumental delivery, which is referred to as a delivery in which the operator uses forceps and the vacuum or other devices to extract the fetus from the vagina with or without the assistance of maternal pushing. And this requires to be a balanced decision, because to use an instrument to deliver the fetus balances the maternal, fetal, and the neonatal impact of the procedure against the alternative options of cesarean birth or expected management, as rightly Monica said, that many times she saved her skin and could offer a vaginal delivery. And there is nothing as satisfying as a vaginal delivery, despite its associated morbidity and sometimes very unpredictable outcomes or consequences. Still, a vaginal delivery, even if with an instrumentation, is found to be extremely satisfying for both the clinician as well as the patient herself. So whenever we look at both these instrumentation, they are both safe and reliable, of course, with proper application and selection being very, very important. And therefore, as we have been discussing, the skill of the caregiver, acceptance by the patient, and the clinical circumstances, these three arms are extremely important, and they have to be critically assessed before you take a call of application of these conditions. Now, instrumental vaginal delivery should be avoided in women who are HIV positive, and that's the guideline, to reduce the mother and child transmission. And if the forceps of vacuum is necessary, it's always better to avoid performing an episiotomy in these patients who are HIV positive. Now, let us look at the quick functions of this. When we look at the vacuum, it's a traction on the fetal scalp, and which is help is taken of the maternal expulsive efforts. Rotational forces are encouraged, and correct attitude of the baby's head is extremely important. If there is deflection, then you may land up in problems, and there has to be judicious application, use of pressure, and the attempts then we're using. Likewise, in forceps, if you see, it is traction, rotation, flexion, extension of the fetal head, and the compressive forces of the forceps itself, which come into being. So all these ergonomics and the geometrics, as I call you, it has to be properly understood when we apply them. And therefore, there are certain very, very important quick things that one has to remember. For example, if you're applying the vacuum, it's extremely important that it is applied on the correct flexion point or the pivot point, as it is called as, which is typically at such a position towards the posterior fontanelle, right in the center of the sagittal suture and behind the anterior fontanelle, wherein if you apply pressure, you are automatically going to maintain the flexion of the baby's head. Now, if you fail to do that, and if there is a little lateral application, as you can see here in the pictures, then you may have the wrong diameters getting presented to the pelvis, and that is the reason when you would land up in problem. So studying the baby's skull architecture, its attitude, whether there is any lateral inclination, which is called as asynclitism, all these things have to be properly studied, and the station, of course, because that's very important to identify when it is really going to be judicious. And today, we have an extremely wonderful device which we can use in our labor rooms, and that is the Kiwi forceps, because it's a very, very simple instrument, has a wonderful pressure which is automatically attached, a little expensive, but according to me, I feel it's one of the best instrumentation that you can use for vacuum or a ventouse delivery. Now, similar way, when you're trying to deliver a patient by a forceps delivery, it is very important that one applies the forceps with what is called as a correct cephalic application. Now, you can very well appreciate in these pictures here that correct cephalic application is taking into account the distance of the sagittal suture from the basis of the blade. And they are equidistant, exactly attached, completely wonderfully. Now, if you have a baby's head which is completely rotated, then your cephalic and pelvic applications would be absolutely the same ones. But you can see in the picture below here that there is a little bit of deficient rotation. Here, if you try to apply a cephalic application, your application will be wrong. So you have to ensure, again, know what is the position of the fetal head, what is the attitude of the fetal head, what is the station, and then accordingly, you will be applying the forceps in a correct cephalic application, and that can also help you in rotation. Now, typically, Monica was speaking about the outlet forceps. Whenever you have a deficient rotation, it is always smarter to use the short Simpson's forceps, which does not have a pelvic curve. And therefore, you'll be able to rotate the head when the rotation is deficient. But if you have a complete rotation, then the best forceps, the lighter version, is the Wrigley's, which also has a pelvic curve. And that can help us in ensuring that the delivery is safe and without any problems. And you can appreciate here that this is a completely wrong application. Here, the baby's head will slip. There can be injury to the baby's soft structures. And therefore, the correct determination of the orientation of the baby's skull in the pelvis is very important to apply the forceps correctly. Now, it's always smarter in forceps or in vacuum delivery to do something which is called as ghosting. So what is this ghosting? Ghosting is a phantom application where you are assessing the fetal position and station. You are learning the instrumental orientation. How am I going to apply it? When am I going to give the traction? How much time it will require it? And this can also be nowadays, and I'm going to come at the end to this, be aided better by doing a transperineal real-time ultrasound so that you are able to perform these procedures without any challenges. Now, you have to also remember that whenever we are applying the traction, there has to be the right force. And I remember our professor, and one of our professors, which we are very fond of that time, who used to teach us forceps very wonderfully, was Professor Telang, Sneha would assist. And he used to teach us in his lectures saying, the application, the force of application of the forceps ideally should be only of that much strength which your two forearms can begin in. So it would be only when your two forearms, and then he used to call some strong person and he say, you maybe have to apply only the amount of strength that is there in your one forearm. So do not go beyond that. And then he used to give us one wonderful story that there was this story that the JR applied the forceps, then the SR went and caught him, then the CR came, then the lecturer came, and all of them pulled the baby out, along with the mother's bladder, rectum, and whatever else could come out. So therefore, we have to be sure. This was, of course, a story to make us understand things. So we have to remember that the force that we apply and the direction of the force. So you can see that typically the left hand is holding the forceps arms down so that the direction of the force is going up, following the curve of Keras. And then you are going along the curve of Keras and pulling it out. So this understanding especially is important because sometimes, even if we don't apply in the modern obstetrics the low mid-cavity forceps, but Sneha would agree to me, and even Monica, I can see, is applying so many forceps. We have to sometimes apply a low mid-cavity as well, because the patient is trying to push down, everything is fine, but the baby is just not coming down. Sometimes giving a little traction may be essential, but all the evidences say that outlet forceps is the safest ball game today. But if you are experienced enough, if your judgments are proper, you can consider applying a low mid-cavity, where especially taking into cognizance the curve of Keras, which is the pelvic curve, is extremely important. Otherwise, you may land up pulling the baby's head in the wrong direction, prematurely extending it, which may cause more problems than solve your problems. So therefore, traction in the right direction and understanding the curve of Keras is extremely important to deliver these babies by instrumental delivery. I would like to even stop here for a moment and say that even if you are doing a normal vaginal delivery, even that time, be very careful when you're handling the baby's head, the baby's shoulders. One of the commonest reasons of shoulder dystocia today is iatrogenic, because there has been unnecessary pulling off of the baby's head without the baby's head being ready to come out. So allow the natural forces to occur. You be there following, look at what is happening, and you would automatically allow a normal passage of the baby's head. So a lot of patience and understanding of this progress is important. So now when we look at the indications in a forceps delivery, they would be similar to a vacuum delivery, but with a change. And that is when it is a deflex attitude of fetal head and a malposition, especially the posterior positions, or if there is asynclitism, you'll have to be a little wiser because these are all happening in the upper level. So you must be sure that the station is down and then only apply the forceps. In vacuum delivery, compromise mandates immediate delivery would be an indication. Failure to deliver in spite of appropriate management of second stage. For shortening of the second stage, especially in women who have cardiac diseases, cerebrovascular, neuromuscular diseases, and maternal exhaustion. And these are the same ones that can be applied. Just a moment, I'll just take this phone call. Hello? Thank you. And the contraindications for these are absolute. This is non-vertex presentation, preterm, face or brow, unengaged vertex, incomplete cervical dilatation, cephalopelvic disproportion, and relative being mid-pelvic station and unfavorable attitude of the baby. Now, in an instrumental vaginal delivery, important management option for patients in the second stage of labor whose clinical situation requires a quick delivery. And there has been a decreasing trend of using either vacuum or forceps during delivery, which coincides with the increasing rates of cesarean delivery during the past 3 decades. And therefore, we always consider, and now we used to always look at this 5 to 6 centimeters long time back, and now it's become true with the WHO labor care guide, new understanding that the active phase of labor starts only after 5 to 6 centimeter dilatation. So be patient. Your patient will get fully dilated, and then you may be able to deliver her vaginally still by appropriate application of instrumental vaginal delivery. So this is a graph which is showing you the prevalence of the instrumental deliveries in many of the countries. They are still practicing. While in India, you can see that there is a drastic reduction of the use of instrumental delivery. And I think this is because we have now started shifting to C-sections and we find them a little more safer. So whenever we are talking of the indications again, now typically these are the ones which the guidelines mention. Prolonged second stage of labor, the examples are more than 3 to 4 hours in a nulliparous woman and more than 2 hours in a multiparous woman. Suspicion for an immediate or potential fetal compromise where there is non-reassuring fetal heart pattern in the second stage of labor and need for expedited delivery, and maternal condition precluding active second stage, such as cardiovascular diseases and the cerebrovascular diseases and so many other morbidities in the mother, the commonest being preeclampsia, eclampsia in our situations, and even women with anemia and heart disease. Now, for a nullipara, a protracted second stage can be defined as no progress, descent, or retention after about 4 hours with epidural anesthesia and 3 hours without. For multiparous women, a protracted second stage can be defined as no progress, descent after about 2 hours with epidural anesthesia and 1 hour without. So if you look at the challenges, safety is very important. You may require anesthesia or analgesia. Safety of C-section is the one which is a cause of concern, fear of morbidity, mortality, mother's choice, and lack of skill. And there can be an error of judgment. So there are certain absolute prerequisites such as assessing the descendant position, fully engaged head, and abnormal palpation can help us many a times. And when we talk of bradycardia, there are 2 theories associated. It can be because of cord entanglement or cord prolapse, or it can be in the second stage because of the slowing of the heart with traction, pressure effect on the brainstem nucleus of the 10th nerve, that is the vagus nerve, and if it remains persistent, it can be myocardium, which fails to cause inadequate perfusion. And if you are there now, currently we are following the labor care guide, which is monitoring the women in the second stage, and you're looking closely to the woman, you'll be able to differentiate whether this particular bradycardia is an innocuous one or it is a physiological bradycardia. Now, ACOG classifies OVD at the fetal scalp visibility. It has reached the pelvic floor. Sagittal suture is in the AP diameter, that is full rotation, and fetal head is at or on the perineum, that is for the outlet. And for the low, leading point of the skull is at station plus 2 centimeters or more and on the pelvic floor. And there are subdivisions where there can be rotation of 45 degrees or less from the occipito-anterior position, of more than 45 degrees, including the occipito-posterior position. So the risks and benefits of OVD for each patient need to be balanced against those for cesarean delivery, and use of forceps of vacuum is reasonable when an intervention to complete labor is indicated, and OVD can be safely and readily accomplished. Otherwise, C-section is a better option. Always meet the prerequisites where the head is engaged, membranes are ruptured, presentation position is known, anesthesia is satisfactory, fetus is of appropriate gestational age and size, and the maternal bladder is empty and there are no contraindications. Now, this looks like a very, very busy slide, but this is something that I would want to bring in here, is a safety criteria for operative vaginal birth. And it says that you can do it. I'm just putting some highlights here on the side. It's important to do it in a well-equipped labor room or an operation theater. Do not use vacuum forceps sequentially, either use a vacuum or a forceps. And correct application only has to be practiced. And you have to be aware to consider trial in theater if our head is 1/5 palpable abdominally, head is in the mid-pelvis, rotation is required, and the features suspicious of CPD are present. So it's better to avoid it. And consider the consequences of failed attempt at an operative vaginal birth when forceps followed by failed vacuum only with vertex at low station. Increased risk of trauma to the fetus and OSE with sequential instrumental use has been found. Increased morbidity for the mother with a cesarean birth in second stage and increased risk of fetal head impaction at cesarean birth. So these are the typical outlet, low and mid cavity forceps guidelines, which we have already gone through. And what is very important is it's always better to avoid a mid forceps delivery because it is associated with a higher rate of several perinatal morbidity mortality compared with cesarean births. And they are also associated with higher rates of trauma, and therefore experienced clinician is essential. Vacuum instrumentation is generally less traumatic for the mother, and the advantages of forceps are unlikely to detach from the head, can be sized to a premature cranium, may be used for a rotation, and do not aggravate bleeding from the scalp laceration. There are important adjuvants which we can practice, and these are bladder emptying prior, episiotomy only if deemed necessary, and intrapartum USG assessment, which can guide us. Now, prefer ventouse over forceps if the gestational age is more than 34 weeks, if that's giving you confidence. But when success is uncertain, primary use of forceps may reduce the likelihood of failure, as use of sequential instruments should be avoided. Abandon instrumental vaginal delivery if it is difficult to apply, does not easily proceed with traction, or the baby has not been delivered within a reasonable time and after 3 pulls with no progress. One should not be fixated on achieving a vaginal birth. Don't be egotistical about it. And the failed operative birth is usually a most common, and the highest clinical factors are occipito-posterior position, macrosomia, primiparity, prolonged second stage, and maternal obesity. Maternal and neonatal complication rates vary widely and depend on several factors which are not independent. Virtually all complications associated with IVD can also occur during a spontaneous vaginal delivery, but the incidence is lower in them. Always give a prophylactic antibody biotic. It is not a routine, depends on your antibiotic policy. Consider episiotomy, consider perineal infections and wound disruptions, and maybe your broad spectrum antibiotic should suffice. And when you compare the forceps and vacuum, it has been found that in vacuum, there is an increased incidence of Keffel hematoma, subgaleal and retinal hemorrhage in the newborn, and there are less serious maternal injuries, while with a forceps, there is less likely to be result in neonatal morbidity, but more likely to result in maternal soft tissue injuries. An increased risk of neonatal cephalohematoma, while more acute maternal injuries and fetal facial nerve injuries have been attributed to forceps, and this is something that we require to resolve. Now, in the current day, forceps as well as vacuum is an important adjuvant to deliver a floating head at the time of C-section. And my personal go-to instrument is always a forceps, but I have seen many people using vacuum also very, very successful. Now, looking at the future outcomes, although short-term neonatal morbidity varies between procedures, developmental outcome appears to be equivalent for both the instrumentation. Now, quickly in the last 1 or 2 slides, let's look at the future. Future is the intrapartum ultrasound. If the fetal position of the station of the presenting part is uncertain, a transperineal or a transvaginal real-time sonography is performed before attempting the operation. It can be used to judge the appropriateness of the vacuum cup application, and these are easily performed as bedside ultrasounds. And there has been a publication comparing transvaginal digital examination with intrapartum sonography to determine fetal head position before instrumental delivery. And it showed that digital examination during instrumental delivery fails to identify the correct fetal head position in about 25% of the cases. And there is where or instrumentation, sonography can help. And you can see that anatomical structures in the infrapubic plane used in this study. And there are certain typical points which are annotated. I'll not go into the details. And these can help us in understanding the direction, the position, and the place in which you can apply your instrumentation correctly, looking at these wonderful sonographic landmarks. Another device which has come up now and people have used and the trial has been made is the Odon device, which in areas that have limited or no access to cesarean birth, this low-cost device has been found to be a better option, safer and easier than forceps or vacuum extractor. And even with people with lesser training than us can use it. And then there are these new forceps, the theory and the Tatius spatulas, which can be used as vectors to just help in maneuvering the fetal head. And this was a result of a meta-analysis in 9 observational studies, nearly 17,000 patients, where spatulas had a similar failure rate as forceps, but a lower incidence of maternal trauma, lacerations, and neonatal soft tissue injuries. Of course, the evidence was a low certainty evidence. So we all are always worried about our obstetricianism, but it will hurt. It will take time. It will require dedication, willpower. You will need to make healthy decisions, require sacrifice. You'll need to push your body to its max. There'll be temptation, but I promise you, when you reach your goal, it's truly, truly worth it. And really now we feel that, yes, it's worth it. Thank you so much. And I take this opportunity and privilege to thank Sneha 1 and to urge all of you to please vote for Sneha, to also help work for my dear friend, vote for Archana, and also to our dear friend from AIMS, Dr. Neena Malhotra. It's very, very important that wonderful people come and they take care of all the academics, the research, and the proliferation of our wonderful Foxy. Thank you so much.
Thank you so much, Dr. Girija. It's always a pleasure listening to you. And of course, everybody know you not because you are our friend, but this praise is for you being a hardcore teacher, and you have been, very passionate about your profession of teaching and updating your knowledge. So we are really privileged to have you, Girija. And over to you, chairpersons, for your comments. Thank you so
Can't
much.
agree more, Madam Sneha ma'am. Perfectly said. And I would request Dr. Rajesh Doshi sir to give the concluding remarks, sir.
Hey, thank you, ma'am. We are extremely happy to relearn our forceps delivery from you, madam. You are a role model of many, many obstetricians and gynecologists in all over India, and I am one of them. You are a really excellent teacher. Thank you very much, ma'am.
Thank you, sir. In fact, it's like a saga going on when Madam speaks, and she is like perfect in every subject whenever I listen to her. Thank you, ma'am, for your blessings. And we would start with the other session. And I would invite Dr. Sneha ma'am to take over for the panel from here.
Thank you for your kindness, Archana. Thank you.
Thank you, ma'am. Thank you so much, ma'am. So I think Sneha ma'am is here, and all the panelists are also there. So we have Dr. Piyush Pai. Madam, would you introduce them?
Yes, definitely. A very good evening to all of you. And once again, I thank my dear friend, Dr. Girija, for, showing, torch. She is the torch bearer for every part of the subject, I would say, every aspect of the obstetrics and gynecology, but especially in the emergency obstetrics. And thank you so much, Girija, once again. We would like to welcome our panelist, Dr. Piyush Kumar Vadalia, who is from Jamnagar, Gujrat, a practicing gynecologist at Vadalia Hospital and Maternity Home since 1999, present president of Junagadh OBGYN Society. So we are very happy to have you, Dr. Piyush Kumar. Please, you are welcome. Dr. Reginald Pinto, who is from the Bijay Medical College, Ahmedabad, now practicing in Junagadh since 25 years. Welcome, Dr. Reginald Pinto. and Dr. Gaurav Rathi, who's the consultant obstetrician and gynecologist from Jamnagar. Welcome, Dr. Gaurav. And Dr. Manish Trivedi, who is the practicing obstetrician gynecologist, rather practicing gynecologist, interested in advanced fetal sonography and high-risk obstetrics, past president of Bhavnagar OBGYN Society. Welcome, Dr. Manish. We have Dr. Jay Bhatt, who has completed his education from the College of Physician Surgeon Mumbai, and of course, he's currently working as junior resident doctor for GMERS Medical College, Porbandar. So we are happy to have the young brigade also as a part of our program. Welcome. Dr. Ashish Kumar Kuchria, who is a consultant obstetrician and gynecologist from Asha Maternity and Laparoscopic Hospital, Porbandar. And Dr. Ashish Kumar has got lots and lots of accolades, and he's got a professional experience as a gynecologist at Nakshakiran Multi-Speciality Hospital, Rajkot, and he's got the excellence in the publications as well. So welcome, Dr. Ashish Kumar. And with this, I think without much ado, we would like to go ahead with the panel discussion. I hope you can see my screen, and it is full screen. So can we can all of you please put on your video so that I can make out how many of the panelists are here? Dr. Ashish Kumar, I can see, Dr. Gaurav Rathi, and anybody else? Piyush Kumar. Do we have only Ashish Kumar and Dr. Gaurav? Dr.
Jay Bhatt sir is also there.
Jay Bhatt, yes. So Dr. Piyush Kumar is not here, I think. Somebody is joined as doctor. So if at all possible, Saiti, can you please rename or ask them to, open their video?
Okay,
so, yeah. So friends, I'm sure all of you will agree to me that childbirth is a sentinel event, not only in the life of the woman, but her family as well. You can see the birth is not only intensely emotional, but intensely physical as well. And it is not that easy, 1, 2, 3 push and everything is happy, the baby is delivered and the mother is happy. Of course, our aim of labor is definitely having a healthy baby from a healthy mother, and it should be an emotionally fulfilling experience for the mother. I'm sure that even with you just heard the talk from Dr. Girija, and we were the friends and residents together at OBGYN Department of Vijay Medical College and Sassoon Hospital, Pune. So there were lots and lots of dilemmas as far as the management of second stage is considered. And of course, even today, after so many years of experience, we do face the same concerns as well. During the training periods, of course, you have lots and lots of dilemmas. So without much ado, we just go ahead with the case-based scenarios and discuss the questions as well. So we have this, Dr. I think anybody can take this. I will not address any name. All of you, please keep your videos on so that I can, make out. So Dr. Ashish Kumar, I think we start from you. We have this grand multi-para, 5th gravida, para 4, living 4 issues, and she delivered at home. Placenta is also removed at home. She's brought to the labor ward with profuse bleeding. Her pulse rate is 120, BP is 90 by 50 millimeter of mercury. So from this history and the basic examination, what is your clinical diagnosis?
Madam, based on this clinical history and the examination, I would like to tell that first we will call for help because she has profuse bleeding.
Yeah.
And the first thing in the PPH is call for help.
Yes, your clinical diagnosis is PPH, right?
PPH.
Postpartum hemorrhage.
Yes,
Okay.
madam.
Yes.
Another thing I would...
Yeah, so I give you further findings that when you examine the perabdominally, you find that the uterus is not palpable, the fundus is not felt. And locally, when you examine that there is lots of bleeding and you can see a fleshy mass there. Okay, so even the cervical rim is not felt when you try to examine and explore. So what is your diagnosis now?
Possible diagnosis, ma'am, it can be a inversion of uterus because it is a home delivery or delivered by dye,
Right.
and placenta is removed there. It might be a inversion of uterus. That might be a provisional diagnosis.
Okay, so how do you go ahead with management?
First thing, madam, we will go with first thing. I would like to mention here. We will reposit the uterus manually under general anesthesia, and
That means you will call for help. Only
yes,
you
ma'am.
staff, but also the anesthetist, right?
Okay. Okay.
And you will call for help, right?
Yes, madam.
Yes. And your patient is in shock. So would you like to treat the shock? Yes, we would like to address the shock.
Yes, ma'am.
Okay. Now what will you do? How will you? Suppose you call your anesthetist friend, he's ready to give anesthesia. How do you repose this now?
Ma'am, we will repose it with we will see the fundal that fundal area, and we will by feast we will slowly reposit the uterus with one hand guiding over the abdomen, and with the ongoing uterotonics.
No. If you keep on giving uterotonics, the uterus will become hard, the cervix will become tight, and you will not be able to push that fundus inside, right? How do you do that? How do you do that? See, this is a kind of inversion and the various degrees. So how do you do that manual correction? You can see this image here, but definitely I would give you some better images here. Okay. So you, with your right hand, now can you describe? It is given here nicely. You can describe.
Okay.
Mm-hmm.
Yes, ma'am. Yes, we will reposit the uterus by one hand, and another hand is guiding over the abdomen.
Right.
After repositioning, we will keep fist under the uterine cavity, and
But
maybe.
then how do you see? You can see how it is holding. The surgeon is holding the fundus first. Okay, it's just catching hold of the fundus, trying to go towards the cervical rim, and he will try to repose from the cervix inside, right? So the part which has come last, the cervix is, see, fundus comes down. You must have seen these diagrams, no? See, the fundus dips in the cavity first, in the vagina. Then the fundus will start coming out like this. So fundus comes first, then the body comes, and then the cervix comes. Okay. The cervix comes last. But then when you repose, you have to repose the cervix first. Then the body goes inside. Then the fundus goes inside. Correct?
Okay.
And then you keep your hand inside. With your left hand, you stabilize the fundus. Correct?
Okay.
Okay. And now you give uterotonics.
Okay.
Correct? So we will not give uterotonics. Anybody, any other panelists? Yes, Dr. Gaurav Rathi. Any comments from your side? Please unmute yourself.
Madam, I think if there's a surgery, it's a Hulton's procedure, we can go, or Huntington's procedure will go. Uterotonic, it's supposed to give to relax the uterus so that we can push inside.
Okay.
Hello.
Dr. Jai Bhatt, do you want to add anything here? Please unmute yourself. Unmute. Unmute yourself.
Hello.
Yes. Please go ahead.
Ma'am, as you said, after reposition of the uterus, we can give uterotonics.
Right.
And we will see if the uterus is contracted or not after few minutes.
Right.
And as soon as we can achieve the contraction, we will start correction of anemia, that is blood loss.
Okay. Okay. So once you correct once you repose it inside, you will give the uterotonics. For how long? For how long you want to give the uterotonics?
Ma'am, for 24 hours.
Yes, at least 12 hours you should give, because you want to prevent recurrence. Suppose you are not able to, you're not able to repose the uterus with how you have discussed manually. Then what are the other procedures? Whether you can repose with some other measures.
Surgical Huntington procedure and Holton's procedure, madam.
Okay, so what is this hydrostatic correction? Have you heard of sometimes?
Yes, true.
Okay.
Hydrostatic correction, yes.
Yes. So what is that and how do you do that? Anybody can take up this. If at all somebody knows, we can discuss. Otherwise, we'll just discuss in short and go ahead. Do we have Dr. Piyush Kumar with us? Anybody from the panel who has joined just now? Okay.
Yeah, I'm Dr. Manish Trivedi.
Okay, so Dr.
Yeah.
Manish Trivedi, please go ahead. How do you do
The hydrostatic correction is also one of the method when the manual reposition does not suffice, because when the patient has come very late, the cervical ring may become very much tightened. So the pass which is delivered last has to be delivered, which was to be pushed inside will be more difficult to put inside. So it is the gradual pressure which increased inside the vagina by the fluid. We are with hydrostatic pressure, we can gradually deposit the pus which has come last to inside the vagina and the cervix.
Correct. So actually, this is just to make it short. You have discussed it properly, but then yeah, you have to make a douche of 3 to 5 liters of warm saline, and you have to take a long tubing. Put it, the nozzle, you have to put it inside the posterior fornix, and then you have to close the vagina by closing the labia minora. Ask your assistant to start the fluid under pressure, and with this fluid, the pressure of the fluid, gradually the fundus is getting pushed up and it will negotiate the cervical rim, and ultimately you can correct the inversion. That is what is the logic here. Once you repose, you put in your hand and of course you try and stabilize, give uterotonics. That is again the same procedure. Now you let me know that if at all you this procedure also fails, then what you do. Do we have Dr. Reginald Pinto here? Reginald, do we have Dr. Reginald here? Okay, doesn't matter. We continue with this, and somebody was talking about Halton's and Huntington's. So what is that?
Yeah,
Dr.
just
yeah, please.
in Holton's procedure, you make incision in the posterior surface of the uterus to bisect the constriction ring, and then deposit the uterus. And Huntington, I think you can do an anterior surface of ring.
Okay. So anybody, Dr. Ashwini Kumar? Dr. Ashwini Kumar, do you want to say what is Halton's procedure? Halton's procedure is the simplest one, where you open the abdomen, push the bowel back, and then you try to reach the, the rim of the cervix where the fundus has, inverted. Go beyond that, anteriorly and posteriorly, try to flip your hands like this so that you can, bring out or bring above or raise the dome of the diaphragm. That is what is Halton's procedure. And then of course you can see this. Gradually with both your hands, you flip the uterus like this, because it doesn't have the tone. That is why the uterus is seen like this, and you can just flip it up with the simultaneous movement. That is what, though it is a rare happening, it can happen, and we should know how to repose it. That is why we are discussing this procedure. And of course, you have the Huntington's procedure, as somebody talked about this, that you do the laparotomy and gradually try to lift up the round ligaments, and then you try to raise the fundus with the help of these LEs. I won't say LEs, but some non-traumatic instrument. It may be the Babcock's instruments. Gradually, you pull the fundus of the uterus above. That is what is the Huntington's procedure. And so what you have discussed is the next procedure, the Halton's procedure, where you cannot negotiate any ways. Then you have to cut the cervical ring. Then you take the fundus, you repose the fundus, and then you suture whatever you have cut. So that is what is the Halton's procedure. Okay, and then of course you can do this with the negative pressure like kiwi cup you have just heard for the baby's head. So you can pull this uterine fundus even with vacuum, that is kiwi cup, or even the suction, negative suction, you can do this. And then of course you have various measures. So maybe this is a quite a rare happening, uncommon process, but I'm sure many of you must have experienced even at the cesarean section, sometimes you try and remove the placenta and the uterus just tries to come, but because the uterus is open, you can easily make out that maybe the fundus is coming along with your placenta and immediately you stop pulling the placenta. So in other words, I would just ask you, Dr. Gaurav, that what are the causes for uterine inversion? Why it happens?
Yeah, so there is like big babies when the uterus size is bigger, before contraction of the uterus, we pull the placenta, and there are a chronicity of the patient. They will be reported whom this happens. So basically, three reasons: polyhydramnion, big babies, before contraction of uterus, pull the placenta. Basic thing.
Okay, Dr. Manish Trivedi, can we hear from you? What are the reasons for inversion of uterus? How you can avoid them?
Usually, it is a grand multipara and the uterine atonicity. When the controlled contraction has been applied without the proper method, without suprapubic pressure, if you apply the controlled method and the placenta is little adherent on the fundus particularly, then the cupping of the fundus will start occurring.
Right.
And at the same time, if you don't leave the placenta alone and try to pull more and more, then ultimately it will get inverted.
Yes. So it is your wrong management of third stage of labor, correct? When you are trying to do the active management, it should be a proper brand endosteric where with your right hand, you are trying to give gentle traction to the cord, and with your left hand, you're trying to give a counter traction. So if you don't do this properly, then you can land up into this. Secondly, you may have a fundal adherence of fundal attachment of the placenta. Thirdly, you can have the short cord where you are, you're not getting the idea how long it is and you're just pulling it. Thirdly, atonicity, as Dr. Manish has already said, and of course, the morbidly adherent placenta, where the placenta is truly adherent and you are just trying to pull it, right? So these are all the reasons, but mismanagement or wrong management of third stage of labor, that is iatrogenic reason for uterine inversion, and that is the reason we are supposed to take care of not to happen, because uterine inversion itself will give rise to neurogenic shock in addition to the shock due to blood loss, right? So the shock because of PPH, in fact, it will be over manifested because of the neurogenic shock, what happens because of the pulling and the inversion. So now that by whatever means you have already reposed the uterine fundus inside and you have given the uterotonics, how long do you want to give the uterotonics, and what else you want to do post-operatively? Dr. Jay Bhatt, can you sum up quickly? Yes. For how many hours uterotonics? Whether you want to give any antibiotics, I would give you 2 points.
Yes, ma'am. We can give uterotonics up to 24 hours. Minimum 12 hours, up to 24 hours. And we will give antibiotics along with uterotonics and correction of blood loss.
Right. But you have to be very vigilant for first 24 hours so that, the uterus doesn't lose to recurrence of the uterine inversion should not happen.
Yes.
Right. So we go ahead with the second case now. Dr. Manish Trivedi, this is a case for you. We have this priming gravida, 37 weeks. She comes to you in early labor. You find that her vitals are normal. Contractions are, she's having mild contractions only, 25 seconds every 4 to 5 minutes. The head is floating, fetal heart is good. When you are monitoring this patient without any reason, suddenly there is a drop in fetal heart. What do you feel is the diagnosis? How will you confirm your diagnosis, and how will you manage this case?
Actually, the head is floating, and when there is a sudden drop of FHR, Usually I first do the pervaginal examination to see whether the cord prolapse has occurred or not. Because
Correct.
there is no reason that the FHS would go from 140 to very severe without any contraction. Because it is not the lead deceleration is happening. It is the variable deceleration is happening and sudden drop. It is almost always suggestive of cord prolapse or cord presentation, or so cord is being compressed somewhere.
Right.
So first I will do the examination whether the cord has prolapsed or not. And if the cord has prolapsed, then my first thing is to prevent the compression of the cord by the presenting part, particularly because the head is floating, the less chance of compression, but there is a still compression because the fetal heart has already dropped.
Right.
So there is the I will push my fingers inside the vagina and try to put pressure on the head so that it may not compress over the cord. Second thing, I will immediately go for the cesarean delivery. Immediately I will ask for the anesthetist and I shift the patient to the OT, or sometime if possible. Usually I used to do, when I found the cord prolapse, I used to do cesarean in the labor room itself, because I've got the facility that I can do the cesarean in the labor room also. So immediately I do the severe head low, Tenderberg position, 45-degree Tenderberg position. I may put the Foley's catheter, and sometime I may infuse 200 ml of fluid inside the bladder. So because of the bladder, the head will again push up. So I can remove the finger, and then I immediately, once the anesthetist comes, I prefer that the anesthetist would give general anesthesia in the Tenderberg position only, so that before the delivery, the baby should, the cord should not get compressed.
Correct.
And yeah.
Yeah. So when you will again call for help, prepare everything for cesarean section. You will go for cesarean section as soon as possible. You will deliver the baby, and of course, what precautions you now that you have discussed everything, you will just before the cesarean section, you will once again confirm that the fetal heart is present, right? Yeah.
That is true.
So whenever you have such patient, Dr. Manish, would you like to, are there any measures to prevent such mishaps for this patient when you have early labor and the head is floating? So could you have prevented this situation?
Actually, when the head is floating, I used to do the sonography to know whether the cord is in the presenting part or not. But the cord is already in the below the presenting part, there are chances of cord presentation and then getting cord prolapse when the membrane gets ruptured.
Correct.
So it's more likely to happen.
And
But
when there is no cord presentation, even when there is no cord presentation, once the membrane is ruptured, the cord can descend down. Yes.
Yeah, the cord can descend if the head is floating. So immediately we should go for the pervaginal examination to see whether the cord has prolapsed or not. Even if the FSR deceleration is not there, floating head with rupture of membrane, maybe spontaneous or artificial. So usually 50% of the cord prolapse are because of iatrogenic. When we do the rupture of the membrane, immediately the cord come out when the head is floating. Or sometime to see whether the liquor is clear or not, we sometimes little push the head to know whether what is the liquor is coming when there is an non-reactive NST is there. So we would like to see whether the liquor is clear or not. When we try to push the head, then immediately the cord will come out.
Yes.
Because the cord is getting compressed, and because of that, the non-reactive NST is there.
Correct.
And because you push the head, the cord has space to come outside.
Correct. So sometimes you may not even have the frank cord prolapse. You may not, you will just see that there is rupture of membranes. The cord, the liquor is leaking already. When you do internal examination, you may not feel the cord pulsations. Still, there is fetal severe bradycardia. Now, what is this situation? You may not feel the cord pulsations. You may not feel the cord also, but there is a cord features like cord compression.
Yeah, but that is because the cord is gone outside. Spasm has occurred in the cord.
Yeah, Dr. Manish, my question is, when you have frank cord prolapse, you know that cord has prolapsed, but sometimes it can happen that there is a rupture of membranes. You find that there is fetal distress or fetal brady, but when you examine, you don't feel cord somewhere. Okay. So what is this called as? This is occurred cord prolapse. Yes, yes. By the side of the presenting part, it is just coming along the side It is getting compressed between the
Compressed.
uterine wall and the presenting part. So
Yeah, that is true. That is
cord
focal
prolapse.
cord prolapse. Yeah.
Yes. And rightly, as you did mention about the cord presentation. So can somebody talk about cord presentation? Ashwini Kumar, can we hear from you what is cord presentation and what is its significance? What is cord presentation?
Ma'am, when the presenting part is the cord,
Okay.
from lower side, when we feel by vaginal examination, or we can see by ultrasound examination.
Right.
Or I think the significance we should rule out, I think is vasa previa should be ruled out, whether vessels are traveling from the internal os or not.
We'll go to vasa previa
When the
later on, but then what we are talking about is cord presentation. That means you have your presenting part. The cord lies in between the membranes and the
when the membrane is not ruptured,
Okay, yes, when the membranes are not ruptured. Right. So, like when you have the rupture of membrane, it is frank or the overt cord prolapse. If the membranes are not ruptured, but there is still cord which is ahead of the presenting part, and you can feel it, the pulsations are felt, you can diagnose on ultrasound, but actually the cord is not exposed. That is called as cord presentation. That you can make out before the patient even goes into labor by ultrasound. And what precautions you can take for this patient? Can you deliver such patients vaginally, or should you deliver such patients vaginally?
Ma'am, if the head is floating and the cord is presenting part, we can wait. It might goes away by fetal movement. Or if it is in another examination, if the cord is not of the presenting part, we can do the controlled ARM, we can deliver.
With the
And
cord
if
presentation?
No, not with cord presentation. If it is goes away with the fetal movement or in second examination.
Okay. So naturally, if it is not there, there is no question. I'm talking about the cord presentation. When you can feel the cord pulsations, then what should you do? Whether you should allow her to go into labor, whether you should go for artificial rupture of membranes?
No, ma'am. Artificial rupture of membrane must not be done.
Right.
And you cannot go with the normal vaginal delivery with the presenting part. If the presenting part is the cord, we can go straight forward for cesarean section.
Right. So, Dr. Manish has already discussed the management of the cord prolapse very effectively and urgently. You have to go for this. In fact, the sentence is if the patient is in active labor or maybe second stage of labor, you have to deliver the baby by whatever modality at the earliest. That means if you feel that everything is okay, she's fully dilated and she can deliver with ventouse or forceps at the earliest, even when you are preparing for cesarean section, you may deliver her vaginally if she is fully dilated. But as here, she is not fully dilated and the head is floating. Naturally, she is not going to deliver. And then meanwhile, by the time the arrangement for cesarean section are done, what are the arrangements you can make to improve the fetal oxygenation or maybe to avoid the further cord compression? What is the maternal position, the oxygenation, everything? Yes, Dr. Gaurav, do you want to add?
Yes, madam. We can start oxygen 4 to 6 liter. Yeah. Then, pardon?
How should be the mother's position?
Yeah, it should be a left lateral position or knee. You can put knee chest position. You can put on mother.
Right.
Yeah.
So
And,
either a
and
left lateral position with very deep Trendelenburg position where you can push, I mean, automatically the presenting part is pushed above, right? Or maybe the knee chest position, which is supposed to be the best possible position to avoid the further cord compression. And then, of course, these are the RCOG green top guidelines that, the clinician has to be aware. We have to know what are the predisposing factors like transverse lie, oblique lie, malpresentations and all this. And you have to avoid the aggravating factors like we have to avoid the patient going into labor. Before that only you have to go for cesarean section. Or if at all you have a floating head or bridge, you have to avoid the artificial rupture of membranes. If at all she is in established labor and you find that the cervix is fully dilated or dilated adequately and the presenting part is descending, maybe you can do what is called as a controlled ARM, right? And then you fix up the head and then you can start with Pitocin. But once you have the cord prolapse, there is absolutely no conservative management, but to go ahead with quick delivery of the baby as soon as possible. Only when you find that the baby is dead, then of course it depends on the routine method of labor and delivery. Okay. So that is what, yes.
Only point in, I want to add a, can you use a turbitalin 0.25 mg subcutaneous to reduce the contractions?
To reduce the contractions.
Turbitalin.
Yes, Manish Trivedi, we can hear from you. Should we give turbitalin or, I mean, is she really having very strong contractions? That is the first question.
Actually,
only in an emergency, only what we can do is to give only one injection. I don't think other things are possible except surgery. Like, can we give turbitalin or any other tocolytics?
and I've never tried procolytics because the simple pushing of the head and the filling of the bladder in the situation where I am practicing. Usually the anesthetic will be available within half an hour. We can deliver the baby out.
Sure, sir.
Half an hour is the latest,
We
but
all are.
within 20 minutes usually we can deliver the baby out. So in that case, there is no need.
So we all are practicing same the way you are practicing. We need at least half an hour to get anesthetic. After calling also to get anesthetic sometimes is tough. So turbitalin, all these things, whether works or not, we don't know. We have never tried. So we are just asking you, sir.
No, definitely. See, if the patient has very severe contractions and if she's actively pushing, which is compressing your cord, then of course you may try uterine tocolytics. Okay. But if at all the patient, in this case, the patient doesn't have very severe contractions. So for this patient who doesn't have severe contractions, even the tocolytics will not help you much. Okay.
And all after using tocolytics while doing cesarean, what about the PPH, atonic PPH and all these things?
Yes,
All this.
definitely. That is what we have to take care of. And you have to just make sure that you deliver the baby at the earliest by whatever modality, I would say. Okay. So we go ahead with the third case now, Dr. Ashish Kuchadia. Do we have Dr. Ashish here? No, Dr. Dr. Ashish Kumar Kuchadia. So, right. So we have this case where you have the fourth gravida with 3 previous abortions, 39 weeks. Now she is in labor. She delivers a full-term baby girl. Placenta is not expelled for 45 minutes of birth. What is your diagnosis clinically, Dr. Ashish Kumar?
Madam, clinical diagnosis is retained placenta.
Mm-hmm.
And first we will have to see by ultrasonography.
How will you manage? Yeah.
If it is available, previous ultrasonography, whether it is morbidly adherent placenta or not. If it is morbidly adherent placenta, we should not try to remove vaginally.
Right.
Another thing is, if it is a not morbidly adherent placenta, we can go with manual removal of placenta under general anesthesia. And we can go with manual removal placenta. We can just insert our hand.
So for this patient, what I want to ask you is, your clinical diagnosis is retained placenta, right? Okay. You will not say it is PPH because we have not mentioned that she's bleeding, right? Yes. So yes. It's a case of retained placenta, but she's not bleeding probably. That is why it is not mentioned. So whether you will go for manual removal of placenta straight away, whether you will try in the labor room, or whether you will go for the investigations first.
Madam, we will not try in the labor room for this case because for 45 minutes it is not separated by itself.
Right. Or, it is bleeding also. It is bleeding also. If the placenta gets separated at least from somewhere.
There should bleeding.
Okay. So what I meant to say is your stand of going ahead with ultrasonography to rule out the morbidly adherent placenta accreta spectrum holds true here. Okay. You must. So that is what the message we want to give, that for every case of retained placenta, you should not try immediately go for MRP. Okay. You should always confirm, because the patient is stable, not to be in a hurry. Even if she has, she was bleeding, you will try and stabilize her. You will ask your teammates to do all the formalities, consent, everything. You will manage this patient, but you will put in a probe of ultrasound and you will see at least that it is not a case of morbidly adherent placenta. And once you rule out that, you will go for manual removal of placenta. So how do you do this?
Yes, ma'am.
The procedure for MRP.
Yes, ma'am. For procedure of the MRP, ma'am, we will insert our hand between the uterine surface and the placental surface.
The cord is hanging and you have to remove the placenta. How do you go in and how do you remove the placenta?
Yes, ma'am. We will trace the placental lower edge. After the tracing the lower edge of placenta, we will insert our hand between the placental and the uterine surface. And by side to side movement, we will separate the slowly placenta. And we will go upward toward the site of the placental attachment. And we will remove him by separate, side to side movement.
Okay. Anybody else wants to add? Yes, Dr. Manish.
When the particularly it is difficult to insert the hand between the placenta and the uterus when the placenta is at the fundus.
Right.
Sometimes it is just pulling the lower part of the placenta which is coming in your hand. Try to pull the lower part and try to reach from that to little above. Then try to pull that part and try to reach little above till you completed your entire procedure. So it's very difficult to insert because the placenta is attached to the fundus and you only see the chorionic plate of the placenta. You cannot see the basal plate of the placenta.
Right.
Your approach towards the hand is very difficult. And in the general anesthesia, you should give full relaxation, either be halothane and scoline. Because you should ask the anesthetist to at least the patient should be given scoline. Then the abdomen should be relaxed. One hand should be kept in the abdomen above the fundus.
Correct.
So to try to stabilize the uterus and then try to negotiate with the cord and try to whatever the part comes, you try to pull little, go above, little pull, little go above, little pull, and then this way you can complete entire procedure.
Right. So
Before that, I would like that the catheterization has to be done because the full bladder will be difficult
and two,
in that
two
patient.
precautions. One, as you have rightly said, first and foremost, even if when you don't plan for MRP, the moment you find that you have this patient of retained placenta, you will first check whether the bladder is empty. If not, you catheterize the bladder and make the bladder empty. Secondly, you will start, once you rule out the placenta acquirita syndrome, you will start the uterotonics.
Uterotonic, yeah.
At least 20 units of oxytocin.
That is to be started before only. Once the baby is delivered and patient has not come up within 5 minutes.
If it is not started by then,
start with the uterotonics only.
Yes.
To know whether sometimes the placenta may come out after within 30 minutes of starting with the uterotonics. Yeah.
Right. And of course, what you are supposed to do that when you find that the patient is, a case of retained placenta, but she's bleeding. So maybe sometimes it can happen that the placenta is already separated, but it is just trapped inside. Sometimes because of the uterotonics, the cervix can get closed and it can just get trapped. But unless you rule out the morbidly adherent placenta, you will not try and pull out the placenta. Secondly, as Dr. Manish has already nicely explained that, you have to trace the cord up to there. Then from this, you have to go along the fetal aspect of the placenta, try to reach the edge of the placenta, and then slowly you try to separate, insinuate your finger from this, and then of course, once you separate everything, then you turn it and then you grab it and pull it. So that is what is the MRP, actually the ideal procedure, what we have been practicing over so many years. And then of course, once you remove the placenta, definitely you have to examine the maternal and fetal aspect to see whether you have removed everything, or maybe you find that there is some additional vessels running across, showing that, there is a succenturator lobe also of placenta, which is retained. And yes, Doctor.
Yeah, we can do the usually I used to do the sonography even after removal of the placenta to see whether the beads are present or not, because it is easy to see the placenta, missed placenta beads immediately after removal of the placenta. So usually I have to have sonography by the side of in the labor room only.
Right.
Before and after also.
Yes, and then of course, then you give the uterotonics and
Yeah, that is
you
true.
have given the antibiotics beforehand. Okay, so definitely, as we have already discussed the procedure, but then this definitely needs the inspection on the maternal and fetal aspect both. That is what we have to take care. Okay, so I think this is very well explained, and I think we'll have only one last case. This as we have this second gravida para 1. We don't have Piyush Kumar Badalia with us, right? So anybody can take up this case. We have this second gravida para 1, 36 weeks pregnancy with history of previous normal delivery, correct? So this patient comes to you with strong labor pains and her vitals are stable, fetal heart is good. When you examine this patient, suddenly you find that, cervix is fully dilated, fully effaced, and you find breech presentation. Station is +1. Her pelvis is adequate. How will you manage? Once again, we start from Dr. Jay. We can start from Dr. Jay Bhatt. How do you deliver this patient? Whether you go for cesarean section directly, you go for...
Ma'am, as it is mentioned, cervix is fully dilated and fully effaced.
Right.
At first, we would inform the patient's relatives that it is breech delivery, and if they are convinced, yes, we would take the consent. And if they are convinced,
what consent you want to take? What consent you want to take? Consent for what?
ma'am, consent for we would explain them that it is a breech delivery, and then fetal head can
get trapped.
It can rest, and the station is +1. That means we can wait. If the patient don't want to, relatives don't want to take risk, then we would go for LSCS. As the station is +1, we can go for LSCS.
Yes, but then as you said that even when you take a decision for cesarean section, your anesthetist would take suppose around 20 minutes, so 30 minutes to reach, and by the time she has pushed it, so then what will you do? You have no
Ma'am,
choice
then
but to
we have
deliver.
to deliver. Then, ma'am, we have to deliver the baby.
Then how will you deliver? That is what I'm asking. That is what I'm asking you for, how to do the assisted bridge vaginal delivery.
Ma'am, we would first wait till the nape of neck. Ma'am, till the nape of neck, we would wait for the baby to be delivered. And ma'am, by rotating full back and legs, we would deliver the head.
How do you rotate the back?
Ma'am.
How do you rotate? I mean, do we really rotate the back?
Rotate, ma'am, the rotate is not the word, but we would wait till the nape of neck. The baby to be delivered till the nape of neck. And then, ma'am, we would lift up.
Suppose, she had just pushed the buttocks and then nothing is coming out. And you find that, the legs are extended like this. Then how do you deliver?
Then, ma'am, first we would deliver through buttocks and legs.
Okay.
And then,
but then the legs are completely extended, you can't, I mean, it's not coming. Only the buttocks you have, you want to hook them out, the buttocks. She's just pushing, you can see the buttocks, but nothing is coming. She's pushing a lot. Then what? How do you deliver?
Ma'am, through buttock we have to deliver, ma'am.
Yeah. So how? The legs are extended. Dr. Gaurav?
My builders, whenever we need to do,
yes.
While up to the optic fossa, we need to hook it one leg after another leg.
Yeah.
And after that,
give a tap in the popliteal fossa so that the foot comes, the ankle you can hold and you can pull the leg. Okay. Similarly on the opposite side. Now that the legs, the lower limbs are there, the body, as Dr. Jay has said already, up to umbilicus, the body has come. Okay. Now you can
Yes.
see the scapulae, but both the arms are like, they are knuckle behind. How do you deliver the arms then?
Uh, uh, from the elbow, we need to no, we need to wait for contractions, and we need to wait till the baby's shoulders should come. Then we need to hook the arms
Okay. How
from
to
the
hook the
elbow.
arms? How do you go hook the arms?
We go to shoulder from right hand and then left hand. One another we need to hook the arms.
So Dr. Manish Trivedi will.
So first of all, even if the frank breech delivery, so usually I wait till the umbilicus.
Right.
Till the delivery of the umbilicus has taken place. By that time, usually you can pull the legs out. So don't touch the baby till your umbilicus is seen.
Right.
Because in the breech delivery, it should be the push from up rather than pull from below will be good for the baby.
Right. No unnecessary traction.
No unnecessary traction. Till the umbilicus is seen, you don't touch the baby.
Right.
And then
just maintain the back anteriorly.
Yeah, and the back is anterior, and keep the back anterior. And when they skin the scapula, at that time, usually I rotate by 180 degree. I take the low set delivery of the head. Even if the head is hand is quite extended, because of the you put 180 degree, you have to rotate, keep the back anterior. You deliver the one arm, then you again rotate the baby in 180 degree in opposite side and deliver the other hand.
Correct.
And then you keep the baby hanging in hanging position.
By its own weight.
Push the fundus. The fundus means the suprapubic pressure is to be given so that the head will remain in flexion position. Then you introduce your finger and by pushing on the malar bone and pushing on the above, you can deliver the head easily at that time. So keeping the suprapubic pressure continuously, if the severe suprapubic pressure is given, the head is unreally will get flexed because of that pressure, and you don't have to pull much from below, so that the neck will not get much extended during their procedure to prevent the Erb's palsy.
Correct. So whatever Dr. Manish has already said, but only thing is because sometimes just because of the pressure, the head may not deliver. So what we call it as the after coming head gets trapped. So in such situation, of course, you have to go for some of the maneuvers. And what are what is Burns-Marshall technique or Burns-Marshall maneuver? You just catch hold of the two ankles like this. Ask your assistant to hold it like this. And take a long arc of the baby. Let the baby go on the mother's abdomen. So gradually the head comes down. You have to maintain the suprapubic pressure. So that is what is the Burns-Marshall technique. And even if it is not working, then of course you have what Dr. Manish has discussed, the Mauritius Smelly White technique. With your left hand, you have 3 fingers. These 2 on the malar prominence. This may not go inside the mouth, but you can keep it on the chin. And with your right hand, this on 2 shoulders and this in the occiput, so that it flex the head. So likewise, you use your both the hands and then you deliver. Even if this doesn't happen, then of course you have to go for what is called as the Brecht's technique, also one more, and of course then Piper's forceps, the application of forceps for the after coming head. So this is actually very important because sometimes you may be lucky that by the time you just talk to the anesthetist, call them and talk to the relative, somebody, to your surprise, you just find that the baby is in your hand. That is the best possible thing. Spontaneous breech vaginal delivery can happen and everything will be fine. But sometimes it happens that only half the baby is pushed out and then it just refuses to come out. But there you have to know all these techniques, and of course, without much delay in delivering the baby. But of course, not to do unnecessary intervention, not to give, traction, not to try and rotate the baby unnecessarily. Just see to it that the back remains anteriorly so that, you can deliver the baby effectively in good condition. So what the RCOG guidelines says, can you prevent such situations? Because I'm sure this patient must be either she must be unregistered or she must be the one who has, the doctor has advised for cesarean section, and must be the one who is just not willing. Let me see what happens if I go in labor. So the RCOG says that you should identify such patients. And I would ask you the last question for this case, that can you prevent such situations? If at all you can diagnose the breech at around 36 weeks, can you prevent these situations? Dr. Jay, you can take up this question. If at all you diagnose breech at 36 weeks, what will be your approach to the patient?
Ma'am, we would give the option of elective LSCS at 39 week.
Okay.
If she is convinced, then we would go for elective LSCS.
Okay, 39 weeks. Okay. And what about, suppose she lands up into, but then if
external cephalic version, we are talking about external cephalic version.
external cephalic version is a good option. Have you ever done this?
No, ma'am.
Okay.
During residency, once or twice, that's it.
Right.
Without any success.
Yeah. Yes, Dr. Manish, you want to say something?
No, I did try it during residency, but not after in the full practice. But it has not worked at that time also.
Okay.
I've seen many consultants doing that also during our teaching sessions, but nobody was that successful to completely the external cephalic version. Have you tried any times, madam?
Yes, as resident, definitely we have tried many a times. And even now, this is 32 years of my private practice. But initially, for first maybe around 4 to 5 years, I have tried in many patients. And majority has successfully turned. But they just turn to the head, but they do not remain in cephalic presentation. Once again, they return to the breech presentation, or maybe they just turn to cephalic presentation, but they are so close to term that they do not naturally go into labor and deliver. So even if the ECV is successful, it doesn't help in going into vaginal delivery. Okay, so that is what.
Should we say that the ECV should be obsolete now?
In UK,
Somebody is trying. I don't know whether the ECV is
UK,
really being practiced or not.
Yes, in UK they are still insisting on external cephalic version, and they are still practicing. They say that you must give informed choice to the lady for external cephalic version. You must try it, and if at all she denies, or when you try it fails, then only you give her an option for cesarean section and the vaginal delivery, which is going to have all these complications. That is what is
external cephalic version.
UK.
Yeah.
And that is what is the, yes, RCOG guidelines also say the same thing. Okay. And suppose if you can diagnose this earlier, then what are the parameters to decide that whether she will land up into a successful breech vaginal delivery or she will land up into problem. This is what is just the theoretical interest, Jattuchini-Andrews score. And these are the parameters: parity, gestational age, estimated fetal weight, too low, too high, and of course the previous breech delivery gives you a better score. So dilatation station, all these things. So if the score is between 0 to 4, that means very low, then she is a case for cesarean delivery straightway. That is what the score says. So induction, and any comment, if you diagnose breech, you find pelvis is adequate, do you go for induction of labor? If everything is fine, you feel that she is delivered previously normally, so a strict no for induction. But if she is in active labor, she is progressing well, do you feel that you can go ahead with augmentation? Should we go for augmentation?
Yeah, we can go for augmentation.
Right. So if everything is going well, but basically WHO says not to interfere at all. Let it happen spontaneously, whatever. But yes, definitely as a practitioner, you feel that if things are going well, but little less contractions, you may feel that, we can augment her and deliver her little earlier. So that
ARM should not be done. Artificial rupture of membrane should not be done. Only the oxytocin drip you can start. Even not the misoprostol or should be put.
Correct. So these are the types of vaginal deliveries we have discussed, that it may happen spontaneously or assisted breech vaginal delivery, what we discussed. And breech extraction is the one, how we extract the breech at cesarean section. We extract the baby completely, correct? So this is what the techniques we have discussed. So I think we have only 3 or 4 panelists here, four of you. So I think we will stop here with the panel discussion. We do have very interesting cases. If at all you want to go ahead, we can take one more case. Otherwise, we can stop.
Yeah, we can go ahead.
Okay.
What
So,
other panelists? What are the other?
yes.
Yes, ma'am, we can go ahead.
We can
Yes,
go ahead.
these are very interesting cases. See, this is a second gravida with gestational diabetes. She comes to you at 37 weeks in labor. When you examine, you find that, you know, in 36 weeks, cephalic presentation, 3/5 palpable head, fetal heart is good, and she's 2 centimeter dilated, fully effaced. She progresses very well because she's a second gravida, fully dilated, fully effaced with over 6 hours. Now she delivers, and after 20 minutes of full dilatation, the head is delivered, but the shoulders are stuck. What is your diagnosis and how will you manage? Rather, diagnosis is very obvious, but how will you manage this case? Once again, we start from Dr. Gaurav, then Dr. Ashish Kumar. Yes.
She's a case of
Shoulders are stuck.
shoulder dystocia.
Correct.
Yeah, shoulder
How
dystocia.
will you manage this case?
We can first is once we diagnose a shoulder dystocia, we can call for help first thing.
Right.
Second, we can prepare a OT for surgery. Third, on the procedure we do shoulder
Call for
dystocia
help for what? For what?
call for help for to do procedure.
Which procedure?
Uh,
Because you need help to communicate with people, call other
Yes.
people's anesthetists,
Yes,
neonatologists. You need help even for giving suprapubic pressure or so. Okay.
Yeah.
You need help
McRoberts
so much, so you call everybody.
Yes.
Okay.
Yeah. Most common McRoberts maneuver will do.
Mhm.
In that mother side, we will push towards the
So you can see the head. Where would you ask your assistant to give a fundal pressure? It can, you know, you can see the head. Yes.
no
So there are
fundal
strict
pressure, no pushing, no pulling.
you no nose. So
Yes.
no traction from below and no fundal pressure. And
Yes.
not to become panic. That is also when, because you
Yes.
can see that the head is neck is getting trapped and you feel that baby will die. So you will become panic. Okay.
Yes.
So don't
Uh,
become panic. Don't give traction. Don't give fundal pressure. Okay. So then
Yes.
what you do? Yes.
First we do a proper vaginal examination, heartbeats, empty the bladder. Once we try to diagnose the shoulder's position, first maneuver we'll do is a McRoberts maneuver, where the mother's both the legs will push towards her abdomen.
Okay.
Yeah, so thighs will be fully flexed.
Yeah.
That
Okay. Then
and apply suprapubic pressure.
suprapubic pressure, right?
Yes.
So where
Yes.
do you apply the suprapubic pressure?
Just
Why do
below
you want
the-
to give? Okay, why do you want to give this position like this?
It will increase the AP diameter.
Okay.
And
also
suprapubic pressure will
this will also straighten the birth canal.
Straighten the birth
Yes.
canal. The most
Straighten
common
the
is
birth
straighten the
canal.
birth canal.
Yes.
Yeah, it will straighten the birth canal, and suprapubic pressure will reduce biacromial diameter.
Okay.
So
Okay.
it can pass
But where to give the suprapubic pressure?
suprapubic just below the pubic surfaces.
Yeah, but in relation to the baby, it has to be in relation to
Shoulder. It's
Yeah.
on the shoulder, anterior
Shoulder.
shoulder.
Shoulder. How do you know that? The
Yeah.
baby's shoulder is inside. How do you know which one is anterior posterior?
Yeah, we can do PV, or we can on abdomen palpation we can able to
You can see
identify.
the head is lying outside. You have to give the pressure on
Okay.
the side of the occiput.
Okay. Yeah, occiput. Yeah, from there we can.
Sir. Okay. Then you have to push the shoulder towards the chest of the baby so that both the bisacromial diameter is reduced, right? Okay,
Yes.
so McRoberts maneuver is not only the hyperflexion of the thighs on the abdomen and the flexion of the knees, but also along with this the suprapubic pressure. So both these maneuvers together, they act better for this shoulder dystocia. Correct. If it fails, then what will you do?
In Utrecht manual, will rotate the posterior shoulder to anterior and deliver the posterior shoulder will be the first. Once we rotate 180 degree,
Right.
the posterior center will become an anterior. And if
And
we
why
come
do you
out
want
from
to
the
do that? Why do you want to do that?
to reduce the my equipment diameter, madam, which is stuck. To
You want
remove
to do this because the posterior shoulder is already at a lower level.
Lower,
It
yes,
is
lower
the
position.
anterior one which is stuck. So
And
when
there is
you
a space in the
rotate it,
hollow of the pelvis
anterior
where you
goes
can
down.
do the
Right.
manipulation of the shoulder.
Right. So Dr. Manish, you can discuss this manual, Wood's corkscrew and reverse corkscrew.
Yeah. First, with the holding of the head, the assistant should be holding the head, and then the operator should push the two fingers by the side of the chest, palpating where the chest is lying. From the chest is to go to the shoulder, and then from there is to go to the elbow, and press the elbow so that the arm will come out. So arm will drop down, and take the arm to the posterior position, and then deliver the posterior shoulder, and then you rotate the baby to the 180 degree.
Okay. In fact, you hook the shoulder and you turn it like this.
Yeah.
Turn it like this. Okay. So the posterior shoulder is already at a lower level. It's the anterior one which is stuck. So you have to make the anterior shoulder as posterior.
At the posterior shoulder.
But that also gets negotiated and comes out. Okay. What we don't have to do and what we have to do, that we have already discussed. There are many more maneuvers. I think we have already discussed, and we go ahead with this last case now.
Which maneuver you usually prefer, madam?
Actually, this is the most one. I would say that McRoberts maneuver, usually it is 95% it is
Successful, yeah.
I think more than 95%.
I've never tried any other method because I've never come across the other method to be used before.
Yeah, I think
which method you use after if you're not successful?
This one, what I said is the Wood's corkscrew, because that is the only one. Otherwise, the other one is very difficult, going from posteriorly and then turning the baby to a short circle. That in fact becomes more difficult. But 95% of the times, I think the McRoberts maneuver works, and that is what it is. Only few cases we have tried Wood's corkscrew methods. So we have already discussed all the maneuvers, and we come to the last case, I think. I think we'll skip this partogram, and this is the one. We have this 37-year-old second gravida previous cesarean section for fetal distress, and she presents to you with labor pains, 2 to 3 contractions in 10 minutes, each lasting for 30 to 40 seconds, no scar tenderness, cervix is fully dilated, cervix is 6 centimeter dilated, fully effaced, vertex is at station 0. At full dilatation, there is severe bradycardia. So vertex is at +1 now. There is fresh bleeding, more than average, no contractions. When you catheterize the bladder, it is blood urine. The diagnosis is very obvious. How will you manage this case? And what is the diagnosis you feel? Yes, Dr. Jay. The diagnosis is very obvious. In fact, I have just kept this case for management. How will you go ahead with the management?
We would go for elective LSCS. Emergency LSCS.
Question of elective, she is already into
emergency LSCS. Sorry, pardon.
So
emergency
it's a case of rupture uterus, and
Yes.
you have to act fast. So how do you go ahead with the operative procedure, and what precautions you should take during exploration, all these things? We will not cover the theoretical aspect for this. It's a simple case, rupture uterus. But then when you are doing cesarean section, what precautions? I think Dr. Manish will cover this, and then we'll close the panel discussion.
Yeah, if the rupture uterus is there, then after opening the abdomen, first we'll inspect where the rupture is there. So if it is possible that the bladder is not very near to the site of the rupture, then we can just extend the part of the rupture and deliver the baby out. And if we see that the rupture is very low, then many times it may be possible that we may put the incision above, try to deliver from above, and try to suture, and then you see the rupture site is very less amount. So we don't have to, otherwise if the incision is very low at the site of the bladder, then after delivering the baby, you will see that the rupture is already extended into the cervix, and a very difficult surgery would have been there at that time.
Right.
So usually my strategy is that if the rupture is very less and it is in very low part, then I put separate incision above the 2 centimeter or 3 centimeter above the that rupture site, and I suture that part, and then we'll see, because the uterus is now contracted, the rupture site is very less, and so we don't, sometimes we may not require suturing if it is not bleeding, because the previous cesarean scar is very clean, and sometimes it may not bleed so much.
Okay. So you
So
have
just
taken
the hemostasis, yeah.
Yeah, you have taken the separate incision, you have delivered the baby. Now what do you do?
First, suture the normal LSS incision that you are suturing routinely, and then we'll look for the separating of the peritoneum down till the push the bladder down as far as possible. Beyond the rupture, beyond the 2 centimeter of the lower segment of the rupture, you should be exposed.
Okay.
And then we'll see, then we suture the subdural site.
Right. So you have to explore, don't get relaxed that yes, the uterus has ruptured from this side. In addition to this, you have to look for other hematoma.
Other side also, broad ligament hematoma may be present sometime, because the rupture has gone extended laterally may involve the uterine artery, and sometimes the broad ligament hematoma may be present at that time.
Right. So that is what, so here it is not only cesarean section, it is as good as an exploratory laparotomy. So you have to actually deliver the baby as soon as possible, and you have to explore and look for other tears and extensions. You have to look for even, the rupture going into the bladder, as Dr. Manish has already said, and you have to actually look for the other hematomas as well. So I think I can see Dr. Gangadhar Sahu sir joining still. So we can have few comments from you, sir, as a senior obstetrician and of course a professor. Over to you, sir.
Okay, thank you. So I am very sincerely listening to, just like an undergraduate student, to your discussion. So I want to just share a few of my experiences and some valuable comments on your panel discussion. Particularly now I will discuss something about our breech delivery. So the case which you have discussed, basically in case of, in today's scenario, we are breech phobic. Once you diagnose a case of breech earlier, the mother is unfortunate that she will land in cesarean. But once it comes to the labor room in the second stage of labor, so you must learn how to deliver a breech.
Yes, that is
so
what
how to
we have
deliver.
given.
Yes. So first principle, our teachers, their teachers, they have taught us that masterly inactivity is the principle. Never interfere unless otherwise warranted. That is the golden line for the breech management. Don't be in a hurry. Don't be panic. So there are 4 steps. Episiotomy is a must in breech delivery because it straightens the birth canal. So automatically delivery becomes easy. Once you do an episiotomy, automatically with uterine contraction, the breech will be delivered and wait till umbilicus is visible. Then your next step of action starts. Once umbilicus is delivered, pull a loop of cord. 2 regions. Number 1, if it is loose, then you can pull it. Suppose by chance it is tied somewhere and it is tight, you can clamp and cut the cord and deliver within stipulated 10 minutes so that nothing will happen to the baby. Second, again masterly inactivity. Wait till the lower angle of the scapula is visible. Then your action starts. Feel for the arms, whether they are flexed on the chest or extended. If extended, it becomes abnormal. Then you go for Lopsett's technique, 180 degrees this side, that side. If flexed, allow it to deliver. Once the lower hairline is visible, that means head is totally in the pelvic cavity. Never go for Mauritius spend method. Rather, go for Burns-Marshall technique. Burns-Marshall technique is included under a uncomplicated breech delivery. So if that you are not accustomed with that, we can go for jaw flexion and shoulder traction, or what you described theoretically, Piper's forceps I have never seen, but ordinary forceps you can apply with valuable techniques. So these are the few things. Another thing regarding should you give fundal pressure in breech delivery? So never. No fundal pressure. Because if you give fundal pressure, head is there, placenta will be compressed, automatically the baby will be compromised. So therefore, never. Once the head comes to the pelvic cavity, then you give a suprapubic pressure. So that is more important. So next thing is regarding external cephalic version. External cephalic version is such a simple technique, but it has vanished from the practice because we are afraid of this. The external cephalic version in majority cases fails. Why? Because it is not being done or conducted properly. So the ideal time is after 37 weeks, 37, 39 weeks. So that baby is mature. So with full preparation, you should go for an external cephalic version without any contraindication. If you follow stepwise, if you are successful, usually the head remains in the pelvis. After complete version, push the head into the pelvis so that it will remain. So therefore, external cephalic version is now should be done with proper guidance in the OT setup. If any complication occurs, you can take off for surgical, LSCS. So this much regarding many things that we discussed, time is less. So this is my view regarding this breech delivery alone. So another thing regarding forceps delivery from my experience. So most of the time, which is the very much deceptive for the obstetricians, will be tempted to deliver, apply forceps, or you should not. We will be tempted. The only thing which have deceived me is a large caput. Many a time the caput will be seen in the +2, +3 station. You will be tempted that yes, head has come, but don't be deceived by this caput succeeding. So palpate in the abdomen for abdomen, automatically you will feel the fetal head. So then you can go for cesarean section even if the caput is seen outside the vulva. So I enjoyed your session, Sneha. Thank you for inviting me.
Thank you, sir. Thank you so much.
Wish you all the best and pray Lord Jagannath to bless you and all others who are contesting for this chairman, Foxy elections. So wish you all the best. Thank you once again. Thank you very much.
Sir.
And special thanks to Dr. Manish. So Dr. Manish has almost participated in almost all the cases. So really a special thanks to you, Dr. Manish. So nice to meet you, and the discussions were nice and it is methodical. So wish you all the best in your practice. Thank you very much. Thank you.
Thank you, sir. Thank you. So I would just say that yes, definitely anticipation, intelligent anticipation, skill supervision, prompt detection, and effective institution of therapy can prevent the disastrous consequences. Of course, not to forget the communication and documentation. So with this, we conclude our panel discussion. And once again, yes, Dr. Manish.
Yeah, what do you do when you see the rupture and when you open the abdomen? What is your experience? How you proceed? Usually, I want your experience.
My experience. So in rupture, it was particularly in previous cesarean section. So one blessing in disguise is that the scar ruptures. Usually, it is not the lateral ruptures. In 99% of cases, it is a scar rupture. So after opening the abdomen, if it is incomplete rupture, nothing doing. So I mean, don't worry. Even if it is a complete rupture, baby is outside, I never go for another, incision outside above this original or the first scar or the incision. The first step is deliver the baby and keep it out. Once the baby is delivered, you get space. The uterus should be retracted. If not, you can, if it is incomplete, if there is not severe bleeding, you externalize the uterus and inspect where is the rupture. Then it is easy to, if you want to preserve the uterus, it is easy to repair the scar which has ruptured. And again, the risk is there, that should be explained. If not, go for subtotal hysterectomy.
Yeah, I think unless it is totally irreparable and it is, it is very rugged, or it is either going with the into the broad ligament where you have, the risk of large hematoma where you cannot actually trace the vessel. I think that is the best way that you go ahead with hysterectomy. But where, as and when possible, as we all of us are trying that maximum times, and majority of the times, you try to repair the rupture and of course try to conserve the uterus. So definitely, what is your
Then if I will preserve the uterus, simultaneously I will definitely go for sterilization operation.
Correct.
A must.
Definitely. So, but then you don't have to, as you have rightly pointed, you don't have to stress on conserving the uterus also. When you feel that either there is lot of, rugged incisions, or it has extended into the angles also, you find that maybe later on there can be large hematomas, and maybe sometimes, the patient has some history of intervention, and maybe she is having lots of infection when you are suspecting. These are the cases where you have to go for hysterectomy on priority. I think
so
that's
not only from the surgical point of view, you have to study the different other factors regarding the risk of anesthesia, risk of blood loss, how many hours the patient can stand this operation. So many things are there. So only for the sake of preserving the uterus, and patient is in shock and bleeding, the anesthetist is in giving alarm bell that finish it. So many things are there. Therefore, that should be on the spot decision. Your sixth sense works.
Right.
So your assistant will tell the right thing, not you. So believe on the words of your assistant at that time. So therefore, the second opinion is more valuable than the first opinion of yours.
Right. So we thank all of you. First of all, I'm very happy that though only four panelists were there, but all of them very, very good. And I'm happy that, the young generation has accepted to be the panelists, at least for the obstetric panel discussion. So hearty congratulations to you, Dr. Gaurav Rathi, Dr. Jayabhat, and Ashish Kumar Kuchadia.
Thank you, madam.
Thank you so much, Dr. Manish Trivedi, for your very valuable inputs and very interesting discussion you had. Definitely, it is, I'm sure it will be a learning for you all.
Yeah, true.
Yeah.
It was good learning, yeah.
Yeah, that was for the younger ones, I'm saying, and it was good inputs from your side. So I hope all of you have enjoyed this. And it is obstetric is my passion, and I continue to work as a high risk or rather hardcore obstetrician since last 32 years. And with this passion, I have continued my passion for academics and social work. So I'm happy that I could reach to all the friends and trying to go ahead. So I seek your blessings and your wholehearted support for my candidature. So I request your support. Thank you so much.
All the best, madam.
So last words now. Last word.
Yes, sir.
One sentence only. So when there is shortage of the panelists, you could have called me to be a panelist. I could have been happy there.
You were always there as an expert panelist, sir. You were always there as an expert for the panel.
Number two. On behalf of the panelists and myself, I thank you very much as the moderator for conducting this panel so nicely. So thank you very much. Once again, my good wishes to you and the prayer of Lord Jagannath. I just ventilate to you. Thank you.
Thank you, sir.
Namaskar.
Thank you so much. Thank
Namaskar.
you.
Namaskar,
Bye.
dear panelists. You have done a nice job. You have also kept me totally sitting silent for 1 hour, listening to all of you. That is my pleasure, and that is also my passion. Thank you. Thank you very much.
Thank you.